for learning. This is a session 21 on the occasion of World Tuberculosis Day. Intraocular TB has been something we deal with very commonly in our clinical practice, yet it is a common challenge for every one of us in terms of diagnosis, in terms of management. So today's session is particularly relevant as we focus on the current guidelines, which will help us refine our approach and decision making. I'm sure this is going to be a very insightful and a practical session for all of us. Without taking much time, I'd like Dr. Bhavik to introduce our guest, speaker, and panelists. Dr. Bhavik.
Yes, thank you so much, Dr. Ganesh. So, as Dr. Ganesh mentioned, on the behalf of World Tuberculosis Day, which is observed every year on March 24th, that is today. And this day marks the historical day in 1882 when Dr. Robert Koch discovered this Mycobacterium tuberculosis, which is responsible for tuberculosis, right? So today we are very lucky that we have this session on current guidelines on intraocular tuberculosis, which will focus on this updated perspectives into intraocular tuberculosis. And it is my pleasure to introduce our panelists and the speaker as well. I'll start with the panelist. We have Dr. Chitranjan Mishra. He is the head of veterinary services at Trilochan Netralaya, Odisha. He is a very dear friend, a highly accomplished veterinary surgeon with over 5,000 surgeries and more than 100 PubMed index publications. He's made significant contributions to retinal imaging, diabetic retinopathy, and ophthalmic research. We mostly see his images on either ophthalmology or AO covers. That is his hallmark. I wonder how he gets them. So, coming to our next panelist, Dr. Kalpana Babamurthy. Again, it's a privilege to introduce ma'am. She's a stalwart in the field of uveitis and ocular inflammation. She currently heads the Department of Uveitis at the Prabha Eye Clinic and the Vitala International Institute of Ophthalmology in Bangalore. With over 175 peer-reviewed publications, numerous international leadership roles, including the president of the USI, and extensive global faculty experience, she is a true authority in intraocular inflammation. And last but not least, we have Professor Rupesh Agrawal. He is an international renowned clinician scientist in ocular inflammation and infections. He serves as head of research at the NHG Eye Institute in Singapore and has led multiple global collaborative research platforms with over 400 publications and H index of 62 and significant contributions to the translational research and AI in ophthalmology. He stands at the forefront of innovation of field, and we are all delighted to welcome him. So thank you so much, Dr. Rupesh, Dr. Chitranjan, Dr. Kalpana. All over to you, Dr. Rupesh.
Thank you so much. First of all, let me just share my slides. Oh, sorry. Is it the slides visible? Are the slides visible?
We can see on ocular tuberculosis, past, present, and future.
Fantastic. Yes. Thank you. So, at the outset, I like to thank each one of you for attending this forum, and particularly on this day of TB Day, World TB Day. I thank each one of you. But let me first start by saying thank you to Dr. Chitranjan. Now, why do I say thank Dr. Chitranjan for introducing to me such a promising young faculty from ASG Group, Kaushik Tripathi. And I met Kaushik last year on 22nd November, one day after my birthday, and I was there. And then that was the first time I got introduced. I was very impressed with him. And while coming back from Baranpur to Calcutta, I was astonished the work he's doing there and all. And then he asked me whether we'll be able to speak to the team at ASG, and that is how I'm here. We tried to do it 2-3 times, but every time something else was happening because this talk was probably going to happen on the World TB Day. So Kaushik, probably that was planned and destined, and therefore the talk continued to kind of getting cancelled every now and then. But thanks for getting me here. Then I'd like to thank the team, Dr. Ganesh Pillai and all, for having me here, and glad to know that the academic focus of ASG Group. So thank you once again for having me here. But definitely thanks to my dear friend, Dr. Kalpana, who is the president of USI, and thanks to USI for supporting this talk and supporting all the scientific talk which is happening under the radar of USI. So thank you once again. So with that, I'd like to get into the journey which we had it's just not about the current guidelines and the practical, but also for some of the young researchers on the forum, it is also about how do you pursue a topic of interest and all. So I'll tell you quite a lot of story as we kind of move forward, and please feel free to interrupt me anytime. I don't want to keep it completely didactic and all, and we can keep it as interactive as possible. But there's a lot of things which have gone in this 13 years of journey, probably even more about the ocular TB. And let's see. So first of all, I like to acknowledge thanks to Dr. Vishali Gupta, who has been a real support, and therefore her name does not go into the last. It's in the first slide itself. That all through her mentorship, and this is the work which I'm going to present is all joint effort, and it's just not my work or this thing a teamwork, but largely due to the mentorship of Dr. Vishali Gupta. I think she does not need any introduction, and if I've done anything, it's just all with her mentorship and Dr. Jyotirmay Biswas mentorship. So once again to acknowledge the name of all the mentors who have shaped up this journey of COTS was Professor Carlos Provisio, Professor Van, Professor Kempen, Professor Amod Gupta, Professor Jyotirmay Biswas, also the COTS collaborator, and lots of patients who have I've interacted, and we learn a lot from the patient. So what I've done, we kept the talk into different sections. So one is the history of ocular TB. The reason is that because I think sometimes history is also important for you to know that you're not dealing with something very unique. It's been going on for some time. Then the burden of what is happening of the TB and the extrapulmonary TB. Where do in that burden ocular TB stands? What are the current clinical signs, and how do we identify that ocular TB can be there? What are the current treatment guidelines? Then also, of course, about our study, COTS study. Then the tool which all of you can use, COTS calculator. I think some of you might be using. If not, then I can show how to use this tool. And then some of the nomenclature. And of course, AI need to be kind of spoken in every single thing. But happy to stop at any stage wherever you feel this is not something which you are expecting and something which you want. We can always keep it interactive and panel discussion can go on. So just as a background, this is a old data which keeps coming up every now and then because we really haven't done that much, but we do know that ocular TB does exist, and there are quite a number of studies which are going on, and it does associate it with morbidity. But this is a diagram which we drew in one of our article, and we wanted to see from where did the TB started, and it dates back to 1650. And since then, the things have been going on where the different time points, different things have been described. So this is we have published in one of the articles, and this was an entire journey of TB. When was the first the term came up, what did happened, and all. So you can see the journey from 1650 till today, where still we find it difficult to convince our respiratory colleagues, our TB colleagues, that such an entity does exist. So you can imagine such a long journey for this particular entity, though through the efforts of USI and many people, we are still able to get it listed into ICMR. But you can imagine the tough challenges which we had in getting across this. So this is a beautiful diagram which shows each and every step and captured most of the milestones which we need to know about it. So sometimes it is good to kind of go back and then look into the history. Now, epidemiology of TB, I've taken some of the slides from Professor Kempen and Professor Amod Gupta. And we do know that there is a steady increase in the number of cases of TB. Recently also, there have been reported quite a surge in the cases of TB. And this is again the burden and just overall glance at where are the main hotspots of the TB. So this becomes quite important in context of when we talk about the ocular TB. So it is important that we know where is the parent line. Parent is in the terms of the pulmonary TB. Yeah. And then accordingly, we target what are the other areas where the ocular TB need to be focused on. Then along with the TB, pulmonary TB, we also need to see where are the extrapulmonary TB based on the country-wise proportion. So this is again a spread of extrapulmonary TB. So it is extremely important that we know where we are practicing, what are the region around us, and what are the endemicity or the proportion of TB or extrapulmonary TB lying in that area. Now, extrapulmonary TB, there are different forms of pulmonary extrapulmonary TB, and this is a very old diagram. I'm sure there are some updated one, and extrapulmonary TB where all it exists. But you will see that again, I is missing in this thing. You can have everything, but still I is not finding a place when you talk about the extrapulmonary TB. So we are able to try and insinuate eye into the form of extrapulmonary TB, but still, I think it's a long journey before it can be recognized that as a form of a extrapulmonary. So this is one of the challenges which we have faced, and we know that the ocular TB community know that that we face this challenge, but we try to kind of work. Now, again, the epidemiology, which we have already spoken about a little bit about the pulmonary TB, but when it comes to ocular TB, so there are different papers which are published, and you can see the proportion of the TB uveitis patient as seen in different studies. So TB in uveitis clinic population, something will be very important, and some of you, if you really want to do, I think it will be good if USI can take up such a project about estimated burden of TB in the uveitis clinic in maybe 10 or 25 or 50 different centers. So that will be a big contribution to the literature about exactly the burden. You can define the way you want to define, the group can define and can come up with the pan-India population of the burden of TB uveitis, because that will allow us to move forward. While we focus on a lot of basic science research and translational research, but sometimes I think this epidemiologic research is also extremely important. So if such a initiative can be taken up by ASG group or USI, I think that will be fantastic, and it will really give a lot for the literature. Now, worldwide, again, you can see the spread of the ocular TB, but again, these are all anecdotal data, not very powerful studies. So I think a very powerful study is needed in terms of it. So I did try to reach out through the community project to different parts of India where I gone and try to kind of work with a lot of pulmonary TB people and trying to find out, but was not successful. But I'll really appreciate and happy to work with the team in case if we can take up such a project on ocular TB. Burden of the TB, and I'm sure Lancet will be quite interested in looking into such a paper on the global burden of TB or the burden of TB in India. So once again, the global burden thing was highlighted by Professor John Kempen in some of his slides. So what do we learn from the history or the epidemiology? That we do know that from the scattered literature, TB is still a major and high-profile public health challenge. It need to be recognized. It's still an orphan baby. It still need some kind of adoption and some kind of a recognition. And we are developing the diagnostic tool, which we'll be kind of studying in next few slides, also discussing in the next few slides about it. And at least it reflects that there is something which is happening in the community, a small proportion in the extrapulmonary community, extrapulmonary TB community. But we do know that such an entity does exist. So at least this is the essence of the literature, what we got from the publications and from our experience also. There are quite a lot of details, and the questions which I want to answer is, what do you call endemicity? Is that this is America completely TB free? But if someone is exposed to a person with the pulmonary TB for long period of time, and what does the long period of time means? What is the exposure means? So some of the things are still not defined. So for example, if I travel in London Tube every single day for 1 hour one way, 1 hour another way, 2 hours, and I'm sitting beside a patient with open case of a TB. Am I, though I've never traveled to India, though I'm just living in London, UK, does it mean that I get exposed to TB, or that is not considered that because I never traveled to any of the endemic region, then I'm not prone? So quite a number of things which I think has not been answered, even in terms of endemicity, even in terms of exposure. So that really troubles me, and I'm sure we should raise those questions, which should answer at least the basic understanding of how does the TB get thing, how much is the exposure time needed, what are the kind of exposure, how it is defined and all. So those are the unanswered questions to me, and I've some young colleagues from here, if they can take it up, I think that will be very nice. Now let's come to the typical thing which we all are familiar with. So let's forget about the burden. Let's forget about the history. So yeah, typically the patient comes to our clinic and we try to diagnose, but the problem is that we do not know how to diagnose the TB. Most of us, including myself, because we do not know how to treat and when to give TB, when not to give or not to give, and therefore we do not know the outcome of this patient. So this is a slide which I've been using from 2016. So this slide I prepared in 2016. Can you believe this slide still exists, and in 10 years, I'm trying to remove one question mark, hopefully. So maybe at some stage we can remove one or two, both the question mark, but right now both queries are still there because the diagnosis is uncertain, the treatment is uncertain, therefore the clinical outcome is uncertain. So this slide has been going on for 10 years. Let's see whether we are able to kind of solve some of the puzzles related to that. Now, it has been a challenge. There are not strong diagnostic criteria, though different groups have come up with different criteria. But I'm not getting into the details of different diagnostic criteria, which all of you are familiar with. I'll just show some of the cases. Some are from Singapore, some are from UK, some are from India also. But just to give you a glimpse of some of the people who are not practicing retina or not practicing uveitis, these are the patient in which you can start suspecting whether it is involvement of the choroid, either in the macular, extramacular area. You can start suspecting that this might be a phenotype, a clinical phenotype suggestive of TB. Once again, this is a disc-related granuloma. So choroidal granuloma can be sitting somewhere on the retina, near the disc, near the macula or extramacular region. You can start suspecting that this might be a TB. Serpiginous choroiditis, we know that like choroiditis, we do know a lot of work has been done by PGI group on this thing, and we do know such an entity can present. Now, we have tried to write a grant on trying to understand this serpiginous like choroiditis to differentiate from autoimmune serpiginous choroiditis in Western population. Both look same. How do you differentiate one from each other just based on the clinical pattern? Can you just say because it's an Indian patient or coming from an endemic region, this is a patient with a TB serpiginous, and because it's an American patient, Caucasian, it cannot be TB? So I think it is very difficult to say. So this is where I feel AI can be a very powerful tool where AI can see what a human eyes cannot see. So if we can have some kind of AI which can tell, oh, these edges are a bit rough, these edges are feathery, this surface is a bit more granular, this is more yellow, this is more opaque, or this is more penetrating, some of those things. So if AI can differentiate this is a male fundus or a female fundus, why can't AI differentiate this is an infective serpiginous choroiditis versus a non-infective serpiginous choroiditis? So those are the questions which I'm trying to answer for last 18 months. I got an AI scientist, but not been able to kind of do despite a lot of efforts. But if some of you are interested, we are happy to work and then pick up your brains, and then we can probably try and look into and solve that query of infective versus non-infective, and hopefully we can solve so that we don't have to kind of toss a coin and then say whether it is a TB coming like a TB serpiginous or non-TB. Once again, the variety of spectrum of serpiginous like choroiditis you can see here. Yeah, and this is once again a very commonly seen in UK population. Every time you treat the patient gets better and comes back with one recurrence, one small recurrence somewhere on the tip, and then you start doing it, and sometimes you pick it up on autofluorescence, sometimes on fundus photograph and all, and different kind of modalities which we use to pick up whether there is a recurrence of the disease. And I've seen one of the patients just started with a very small lesion and continue to progress and almost occupied half of the fundus by the time I finished my fellowship in Moorfields Eye Hospital. So you can have a very relentless looking serpiginous like choroiditis, even though you are trying to treat, it can continue to worsen. Then in between serpiginous and another entity which I'm going to describe, which all of you must be familiar with, APMPP, there is a hybrid variety. So it's a hybrid world, right? The hybrid cars and all. So this is also hybrid variety between serpiginous and between another entity called as APMPP. So something called as MP genus choroiditis. So it is just based on the pattern, not much to differentiate between the serpiginous and MP genus, but it is just the pattern. So and it is a mix of this APMPP where you have a multiple placoid lesions, and whereas in MP genus you have placoid plus serpentine or plus continuous lesion, and therefore it is called as MP genus. So these are all the spectrum. You can imagine in the choroid you got serpiginous, you got granuloma, you got MP, but it's not over yet. There is another thing which is coming up. There is another thing called as bigger granulomas, bigger lesions called as multifocal choroiditis. So within the choroid, you got a spectrum of how a TB can involve. Now, how it should bother a researcher, or how it should bother a clinician scientist? How does TB manifest in so many different way in an individual? So you can have 5 different people sitting with 5 different presentations. Why? What is that which happens inside the body? Is that the immune system control, the host immune system control, or is the load of the TB bacilli control? How does it manifest in one patient serpiginous, in another patient multifocal choroiditis, in another patient granuloma? Why? Why? Because then only we can go to the root cause and then try and treat it. But that why need to come up as a clinician as we try and treat it. Why does it manifest? So that we can go to the root cause, Anything happens in our home, anything happens in our life, we try to find out why did it happen. So why not in our patients? Why not in science? We try and question, why does this happen? Why does this gentleman got infected, or why does this person is having this particular disease? So if that is not all, sorry if I continue to mix this philosophy with some of the real life cases which we see. But I think that's how the research is about, and that's how probably you can move forward in this journey. Now, the another entity which bothers me a lot is this retinal vasculitis. We have come up with different terms like occlusive retinal vasculitis, some of the other features which we know that, and based on it, we do define that this is a TB phenotype. But again, there are a lot of unanswered questions, and I'm sure we will continue to read the literature from various groups, including our group and many other groups, and then they will continue to define what is the retinal vasculitis, when do you treat, how do you treat, and all those kind of conditions which will come up. But TB can present with, so take home message is TB can present with retinal vasculitis besides choroiditis, and you need to suspect and you need to investigate those retinal vasculitis to identify the features which are typically mimicking of TB retinal vasculitis, and those are typically the occlusive nature of vasculitis. Now, again, the question which bothers me here is, why does TB result into occlusive vasculitis? What does exactly happen there to cause occlusive vasculitis? So if that's not enough, so I had many patients of intermediate uveitis, including one of my cousin from Madhya Pradesh, Bhilai. He presented with this many years before he was 21 year, and we given him anti-TB treatment, and a lot of things has happened in him, but it do present with intermediate uveitis. So it was a real case. Eventually underwent vitrectomy, my cousin, and the TB, the vitreous sample was sent for PCR, was grew TB PCR positive on his sample. And after that, he has not received any TB treatment because the TB treatment was already given. Now it's been 13 years, 14 years. He has got two kids. His family, everything is going on fine. No need for steroid treatment. No need for anti-TB treatment after vitrectomy. Everything is stable for him. Now, but the TB PCR was positive when the last sample was done and sent it out for that. But after that, no treatment was given. So all those things are mystery. And this is also can present in the form of intermediate uveitis. Of course, very commonly seen is the granulomatous anterior uveitis, which we do see, and it also can be presented. So you can see the TB presenting, intraocular TB presenting in different spectrum, and it in some patient anterior, some patient posterior, some patient intermediate uveitis, some patient panuveitis kind of thing. Now, after having seen this clinical presentation, how do you go about diagnosing the ocular TB? So one is the first thing is that when you see a patient clinically, then you should have a red flag or suspicion that this patient might be having TB. You should not be very over diagnosing, but it should not be also neglecting. So if you have a suspicion, then you can go about approaching and doing certain tests. Now, when the IGRA came out, I don't know what the current standard of IGRA in India, because some people say it's valid, it's not valid. We thought we have achieved the gold diagnostic, but still, I think there are a lot of studies which are not showing great results with IGRA. We also did our own study. There were a lot of work done by Marcus Ang and Chi Sun Paik in Singapore on gold, IGRA gold and all those stuff. But to be very honest, it's still not like the gold standard. If you get a positive, you definitely have the TB. We do know that. Now we try to tweak also the IGRA results in small way, because IGRA was shown to be 0.35 positive, which was the quantifier on gold. We thought, okay, if we change it for Indian population to maybe make it 1 or 0.6 or 0.7, and then we tweak the values and we say that, okay, maybe for Indian population, more than exposure of 1 is kind of considered positive. But in this statistical modeling, Bayesian modeling, we were not able to say that convincingly that even if changing the value will allow us to diagnose TB with confidence, with a greater positive. And those were the days when I was just learning some of the statistics, and this was one of the Bayesian model which I drew based on Baram Badogi's very interesting paper published in AGO on changing the value of QFT to 1.5 to diagnose the true positive cases in the community. So those are the kind of research models which you can consider adopting. And we did try to adopt one such model, but we are not very successful. So what are the messages we take home from here that particularly about the IGRA, high sensitivity but poor specificity, and there is still uncertainty about the diagnosis of TB. You can continue to talk about PCR, you can continue to talk about other tests, but I just talk about one or two tests. You can definitely go for MEN2, chest X-ray, CT scan, all those things. But I just thought I'll give you a glimpse of the tests which are probably considered. But of course, you have to take into consideration all the tests as you try to diagnose a patient with ocular TB. Now, I don't have a cookbook for you to say that if it is MEN2 positive, it is IGRA positive, then it is there, because every case is unique. For me, most important is the clinical phenotype, and then based on certain corroborative test, which will help me to diagnose a patient with TB. Now, when it comes to the treatment, now we did quite a lot of work on understanding how the patient of TB should be treated and what the literature say. So you can see there are two, these are not the same, but both published in the same journal survey. One was published in 2015 and one was published in 2020. So we wanted to kind of update how the world, the literature, and hopefully we'll come up with the third series now. So if Durandar can come up, we can come up with Durandar 1, 2 is there, and we can come up with the third one as well. Okay, and we'll see. So that work is in progress to understand what is the anti-tubercular therapy for the treatment of TB, but more or less the same message. So we picked up quite a number of studies, and we wanted to study impact of TB treatment in terms of non-recurrence of inflammation, improvement in inflammation, improvement in visual acuity, and what are the factors which allow them to dictate the outcome. So 28 studies were considered, which were after all this thing. So you can see this interesting table. Improvement in inflammation in the TB group, 92%. Non-recurrence of the inflammation, 84%. Improvement in visual acuity, 69%. So you can see, very nice, right? Looks very good, the treatment outcome. And we did all this forest plots, all kind of things to look into. If it is only anti-TB treatment, 85% of the patient do well. ATT plus systemic steroid, 82% of the patient do well. ATT plus systemic steroid plus immunomodulatory, 85% of the patient do well. So more or less the same, but these are the kind of outcomes which we are trying to get it from the publications which were there in the literature. Then what are the factors which can affect? So we got different ethnicity, age, female, longer duration of uveitis, delay in the diagnosis, intermediate uveitis, higher median QFT values, administration of corticosteroid, administration of immunosuppression, longer duration of ATT, which are the factors which can affect one way or other the outcome in patients of TB. So you can pick up the factors which are applicable to you. Maybe delay in the diagnosis, so don't delay. Maybe longer duration of the uveitis, so don't let the patient get into that. So those are the factors which probably you can say administration of steroids. So for me, it is extremely important that I do not rush in for this corticosteroid till the time I'm very confident that I'm not dealing with the patient of a non-infective uveitis and then ruling out, and then only I start corticosteroid. But if I have to start TB, I start the anti-TB treatment, and then I go ahead with starting the corticosteroid. So it is definitely one of the rules which I follow. So once again, just to go, there are diagnostic dilemma and then there are treatment dilemma. So the treatment is not standardized, varying regime and duration. So I have a patient from US and says, questioning, Dr. Rupesh, you've only given 6 months. Don't you think you should have given me 9 months? Because this is what happens and all those things. So you really do not know whether 6 months, 9 months, 12 months. So this is again one of those prospective trial which we can try and consider doing it, whether 4 drug plus 2 drug. So those are the kind of thing there. And then of course we studied the outcome. Now, ATT can be definitely useful in patient with the suspected. So for me, how do I counsel a patient with when I start a patient on NDTB? I said 70 to 80% of the patient do improve with the treatment in the terms of non-recurrence of the inflammation, in terms of resolution of inflammation. So if you are good enough, you probably will be into that bracket. But that I don't speak to every single patient. You only speak to those eligible patients, those whom you suspect. These are the patients who can have ocular TB there. So the key to message again, the literature is confounding. We really do not know. And therefore, we also do not know the role of corticosteroids. If we are diagnosing, should we be giving, should we not giving? So those are the kind of confusing messages. So you will see Dr. Ganesh has showed and Bhavik has told that I'm going to give the current guidelines, but I don't want to confuse you, but I'm just trying to present you the exact literature. So I'm not trying to kind of present with an algorithm and saying that you should be doing this, because every case is different, so it is not correct for me to just tell you that probably do that, but I have to present the facts before you. So I don't want to leave you too confused after the end of the talk, but at least I want to kind of tell you what is the truth happening. But definitely we can continue to discuss about the current regime I follow, and hopefully if that can help you. Now, with all this dilemma, in 2015, Dr. Vishali and I had a talk, and I was doing my studies in Moorfields Eye Hospital, and Dr. Vishali was, of course, doing, and USI group, everyone was doing. Then we thought single center study is not going to be helpful, and I started. This is one of my first few collaborative efforts, and I think this one really kicked up well because we try to bring in the people together on a web-based platform wherein we created a COTS-1 study, and then we went on to move with the different studies. So what we learned here, and this is one of my student, Dr. Dinesh, and he's doing extremely well. He's done a PhD, and he's with the Ministry of Health in Singapore. But that time he was in MBBS year 2, and we tried to put up a digital platform, and there was no funding. So we wanted to identify how do you still bring the people without any funding, support and all. So this project was done with zero funding. So we try to capture the data, and then we try to analyze the data. How was the data captured? By the very enthusiastic uveitic expert, the academicians. One good thing about the uveitis community, which I'm very proud to say, that all of us work together. We don't have any kind of a competition amongst any one of us. We all love to collaborate, and we have almost zero ego, unlike some of the other subspecialties, which I don't want to mention. But as such, uveitis community is a very friendly community. So I encourage some of you who are not doing uveitis, if you want to be really enjoying the friendly piece, please do join our community. Okay, so everyone, without asking any money, without asking anything, everyone contributed the data. No one asked for anything. It was just a wonderful effort, and this was the first ever photo taken in 2015 in San Francisco. And we were talking about so many other things happened in the San Francisco. Someone was saying me, I said our court study also happened in San Francisco. And recently I was in FOIA's meeting in Sonoma Eye. So David Chu and Professor Kwon Dong Wen were saying it is at this same meeting, FOIA's meeting in Sonoma was started, and at the same time the courts was started. So some kind of a similarity between FOIA's meeting, Foster's meeting, and between our court study. So multiple centers. Sorry if I'm rushing through that, but I'm sure all the colleagues know that, and it is the wonderful efforts by a lot of colleagues, including Dr. Kalpana is on the call, and a lot of people, they put together the data, and we managed to kind of capture the data. So I'm going to rush through some of the slides in interest time, because I know I'm already finished half an hour, but just wanted to kind of give you a glimpse of the data collection platform. It was not a very boring Excel chart. We wanted to come up with a very smart, user-friendly form. So we created this. And you know who taught me about using this form? I was not aware. So one of the high school student, he was with me. He saw me using Excel chart, and then sorry, I'm kind of okay. And then he told me, Dr. Rupesh, why don't you use this Cognito platform? So he was the one in the high school student in high school who introduced me. I think he's now finished his medicine in Imperial College and doing wonderful thing. I'm not in touch, but he, before leaving my clinic, he introduced me to this form. I'm really thankful, because after that I've used this form like anything. So what we did uniquely in this study was we have a strict inclusion criteria, at least at the time of analysis, if not at the time of recruitment. And then we also defined the treatment failure. So this is the first time ever a strict criteria for treatment failure was defined. As you can see, persistence or recurrence of inflammation within 6 months of completing anti-TB treatment, inability to taper corticosteroid to less than 10 milligram per day or topical steroid to less than 2 times a day, or use of steroid sparing immunosuppressive. So this is the first time ever in a retrospective observational study where we were able to insert this strict criteria for treatment failure or inclusion criteria, which typically happens in a clinical trial, but we managed to kind of put those things. Yeah, so this is the overall statistic of how the data was collected and the spread of the data. But you can imagine, you can look into the left-hand part of the menu, and menu card, I call it as, or data card. So you can see we recorded the symptoms, the laterality of the eye involvement, prior history of TB, distribution of prior TB, sites of extrapulmonary TB, chronicity of the uveitis, anatomical distribution of the uveitis, type of choroiditis, the different features on the fundus, then different investigations done in terms of imaging and all. So you need to have adequate information before you can do that. Unfortunately, and this is again a philosophical thing here, is that unfortunately the AI generated reports nowadays are based on 3 or 4 or 5 or 6 variables, which are not enough, my dear friends. We need to have a very granular level of information. We want to do it. I know it's a really painful thing to collect so much of data, but you need lot of factors before you can kind of come up with some kind of a meaningful results. So I think when you design a study, please do take into consideration and invest a lot of times in designing these variables which you need to collect. So that's what we did in our research in COTS. So we invested quite a lot of time, and this is the form which you are seeing now. But this went through multiple iterations, at least 10 to 12 times. We thought, oh, this is not good enough. We need to change. We need to change. We need to change. We need to change. So be ready for that change. So it took us 1 to 2 years before we were ready with the final form. So it is a lot of exercise, and then data cleaning, data analysis, lots of efforts, I can tell you, before we can come up with these papers. So this is a wonderful paper which came up about the global variation. I was talking about the epidemiology, and this did tell us how TB can be different in different parts of the world. And this is the paper Dinesh and I really celebrated. We went for an ice cream after this thing, and I thought, okay, we deserve, because one good thing was that this paper came up, original paper in JAMA Ophthalmology. Not only that, but we really got something very interesting results, which I was not expecting. And I was not expecting the data will give us. So we had this number of patients who were treated with anti-TB treatment, and we do identify that there is a significant number of patients who had a low successful rate, and a very small proportion as a low as a treatment failure. And we were able to identify what are the features which contribute to treatment failure, which were like retinal vasculitis, choroiditis, and uveitis. We can go into the depth of it, why this can be contributed, but there is a reason why this were coming out to be the scientifically, there is a reason why this can be the potentially the contributory to treatment failure. And of course, which are the patient carrying the visual worst visual prognosis and recurrences and all. So this study was very helpful for us, and in terms of understanding the impact of anti-TB treatment in a very, because it is very difficult to design a prospective clinical trial, but at least based on this observational study was done. The other thing which I was very happy with this couple of papers, we were able to do a longitudinal analysis, and based on this, in the paper number 1 in IOVS, we were able to say how it differed between different region, race, immigration, and again, different population, how they receive anti-TB treatment and all. So these were wonderful Kaplan-Meier graphs, which we were able to draw into that. Now, what came up very interesting in JAMA Ophthalmology paper in the Kaplan-Meier graph is the anatomical distribution in terms of the TB treatment received, and the vitreous haze, how it stood out to be a single most important factor contributing to the failure of anti-TB treatment. So just for some of the things for us to think. Now, this paper Anirudh Agrawal decided to take up, and he was able to say that PCR is not that helpful in management of TB uveitis. So this is another conclusion which we had from our study of 900 plus patients. Another study on retinal vasculitis. I'll kind of try to go through this quickly. And we were able to identify that significant number of patients had occlusive retinal vasculitis, and some other key features we were able to identify it, and then how these patients were treated. In choroidal TB, we were able to identify all the spectrum which I have spoken, but I'll show you one of the diagram which I really love it. So this is the spectrum which I have spoken about: choroidal granuloma, multifocal choroiditis, serpiginous choroiditis, empygenous choroiditis, APMPP like. Now I put up a hypothesis that one of the phenotype will be more heavy with mycobacterium, and one of the phenotype of choroiditis will be heavy with immune driven, and therefore there is a spectrum like that. Accordingly, we can treat those patients. So choroidal granuloma, I will treat only with anti-TB treatment. APMPP, probably steroid with cover of anti-TB for maybe 3 months INH prophylaxis. Serpiginous, probably you need both, or maybe sometime you need immunosuppressive, something like that. Just hypothetical thought, some mathematical equation, but I'm not saying I have a science to prove this thing, but this is just a concept, and this is where we thought we'll be able to move the science forward, and I think something need to be done in this particular field. Now again, anterior uveitis, intermediate uveitis, you can see from a well-gathered data how many papers you can write. We also managed to kind of study about the visual morbidity, This is a very interesting paper, Anirudh, and we thought about writing this about defining cure in TB. So pulmonary TB is considered to be cured if there is no recurrence of pulmonary TB for 24 months. So we wanted to study in our paper how many patients had a cure where they did not have a recurrence for 24 months. So not that many, because within 24 months people get recurrences and all. So you can imagine the level of studies which we are doing. We are still doing one or two studies here and there, but by and large, you can see the number of papers which we are able to come out. So these are some of the papers and some of the publications and the efforts which has gone. And there are some of the key take-home points, and happy to share the slides with you, group, and in case if you want to kind of go through that. But once again, the message was here that we need more data, more correct definitions and all. And this was again slightly disappointing that we were not able to formulate an algorithm or guidelines from the COTS one, though we thought we will be able to come up with that. So kind of efforts started winding up in 2017, 2018, but we were not going to stop there. Already the momentum was there. We thought we need to move forward. And how did we move forward? When you get stuck in the literature, when the retrospective studies, the observational studies, or any of the studies are not able to give you the answer, what do you need to do? I think you need to kind of group the people, get their opinions, and get a consensus or a survey. So we try to design the survey of the experts. Now, there are different ways survey can be captured and the information may be captured. But those days, I was trying to study some of the epidemiology and study design. I came across this concept of Delphi study. So Delphi gives you a very structured approach to consensus. So we introduced a Delphi study, and using the Delphi consensus guideline, we did one of the largest ever survey ever in the history of medicine. So we grouped the people together. Quite a number of people were there. Almost 485 questions were there, and based on the clinical phenotype, based on endemicity, based on the specific characteristic of each of the phenotype, and based on three tests: chest X-ray or CT scan, then IGRA test and MENTU test. And based on it, the different questions were designed, and the expert were asked to give an answer between 1 to 5. 1 is where they will not give anti-TB treatment. 5 is where they are most likely to give anti-TB treatment. 81 experts participated, and then we went ahead and did the analysis. So what happened in the analysis is that answers with 1, 2, 3 were discarded. Only the questions, the answers with 4 or 5 were kept. So 5 were clear pass, 4 was borderline pass. So 4 went through a second round, and wherein we went for a meeting which happened in Chandigarh, one of the beautiful meeting, and I really love the concept of this meeting. Not it took us a lot of time, and we had sleepless nights before this, but the meeting went on very well. And in this, we gathered different people, and they all sat on different table. With you see the distribution of the thing, the table, and during this thing, they all did voting and all. After all the multiple exercises, lots of discussion, and I think it was fun. It was real fun for 1.5 days. We came out with this chart. If you get a patient like this, you give NTTB. If you do not get, you do not give, like that. So this chart was there. I was very happy that the chart is there. Went back and we wrote this paper, and it got published in ophthalmology. So that's it, right? You are done, and we are done. We got this papers, ophthalmology final. No, I think this was not the end, because how many of the general ophthalmologists read ophthalmology paper which is full of complex statistics and all? So I was not very happy at this stage, because we got the guidelines. We thought we have done what we can do, but I wanted to simplify those papers, and that is where we introduced this concept of COTS calculator. So I had an enthusiastic student who was every day coming to my clinic and saying, "Dr. Rupesh, I want to do. Name is Ludi, wonderful student, year 4 medical." I said, okay, can we convert this this idea and concept into a form of a digital tool? Because I feel the cataract people, and I'm sure Dr. Ganesh will like that, is like you use all the different forms of IOL calculator. We don't have, as a uveitis practitioner, a good tool. So I thought, okay, we also should have, like in cataract people, an online tool. So we designed this COTS calculator. So in this, all the survey inputs were gone, and what come up with this is a final tool like this, wherein, so what happens here in this is you put in the some of the identifier, not necessarily mandatory, but what you need to do is a country of origin of the patient, so that gives you endemicity, and then you need to identify what type of clinical phenotype the patient is having, where it is active, inactive, tubercular retinal vasculitis, TB skin test, IGRA test, you enter. The only unique thing about this is you get 3 responses. It is not about positive, negative. Also, one is unknown. So sometimes if you have not done the test, also you get that option. So you can write positive, negative, or not done or not known. So when you put in all this thing, you will get a number, and that number will tell you whether this particular patient will require entity. So it takes less than 30 seconds. You can have this tool on your calculator. So you type in oculartb.net, and then there is a COTS calculator in that. You can just download as a screensaver on your mobile phone. So I also use sometimes in my clinic, and it can be a useful tool for you to kind of give you a guidance about whether you want to use it. No AI was required, only mathematical equation and some logic. We managed to kind of get this tool out. So I was really happy that this tool is coming up and people can start converting. And this is all 2 ophthalmology paper converted into the form of nothing different. You read those papers, ophthalmology, and you read this calculator, same. So both papers were on your palm, onto a calculator, but the research does not stop there. You need to still validate. So we validated the COTS calculator. We went back to the COTS 1 data again. So we tested the COTS 1 data and finding out what will have COTS calculator done versus Dr. Kalpana or versus Dr. Rupesh or versus Dr. Vishali. So we challenged the COTS 1 thing and we got some very pretty interesting results. So we were trying to find out, is the COTS calculator better or is the COTS, the expert better? So this is what happens. So 6 months post ATT, clinician judgment 94 patient will fail. COTS calculator with a score of 5 sensitivity is 22.5. But when it comes to specificity, you see, so sensitivity is there, but when it comes to specificity, COTS calculator with a score of 5 is able to tell specifically that 85% of the patient would have had treatment failure at 6 months, or 88% of the patient would have failure at 12 months, and 86% has failure. Whereas as against the clinician judgment based on the real life data, 24% had failure, 29 and 57. Can you imagine that completely different number which we get in terms of when you use this tool? Now, don't know whether it will be helpful, not helpful, but we just wanted to test the COTS calculator versus the actual real life data because we had the real life data. So this paper also we managed to get it published in JAMA Ophthalmology. Happy with that. And then Dr. Biswas from Shankar Netralaya also tested his data with the COTS, and we really got some very interesting result. And so that we thought it is good. We're trying to revise it using some AI tools, using ChatGPT also, so that we can make it better. The work is in progress. Hopefully, we'll come up with the COTS calculator version 2.0 soon. So it is an useful tool. I will skip this thing, but again, sometimes the nomenclature is needed. So we did work on the nomenclature and on the TB. And last but not the least, as I said, I just wanted to touch base on how you can apply AI in TB. So if you would have asked me 3 years before, Dr. Rupesh, where do you see the role of AI in uveitis? I would have said probably no way. I'm not going to use. I was completely away from AI. I really don't wanted to kind of touch that. But in 3 years, it has changed completely my perspective. How AI can be so wonderfully useful in the limited data set, in the data which is heterogeneous, in the data which is very messy, in the people where they are not able to identify. So I think if one place which is there of the AI is the really here, not for identifying diabetic retinopathy or some hemorrhage, because that a human being can identify. So we really are trying to find out how AI can see what a human eyes cannot see, and this is what we are trying to do. So one of the project which we did is about machine learning, and this fellow has done wonderful work, William, who was with me for a couple of years along with Carlos. Both of them, they did work on identifying if we put this data and try to generate some of the AI network, can you come up with a better tool? So we got some pretty interesting result about saying that if we have the AI model and AI model is converted into an online tool with you using as a clinician, so we can probably be able to predict the treatment outcome. And this was the output of that paper. We are trying to now convert it into a real life tool so that you can use it as a COTS predictive outcome tool when a patient comes up in front of your clinic. So there is a role of AI in not just in medicine, but also in rare disease entity like ocular TB, which we are able to show only just from 600 700 patients. Not that it requires a lot of patients kind of thing there, and it does show that. So this is some of the journey which we had that, but these are just some of the names. But I can just say you that it was a whole lot of team effort, and it was a journey which we all live together, and we are still doing that journey. So once again, I am thankful to all the collaborators who has had trust in us, and to all our patients and everyone, and to everyone around us for believing in us. So thanks once again for your patient listening, and thanks for the opportunity, Kaushik. Thank you.
Thank you so much, Dr. Agrawal, for your wonderful insights and providing us with the ideas of how does epidemiology play a role, the diagnostic modalities, what kind of treatment do we have to come to, and a very good model for us to understand where does a patient fall into what category and what treatment to start for such patients. So I'd like to start off with comments from the panelists. Uh, you have any comments for Dr. Rupesh, or we go ahead with the questions? Dr. Kalpana?
At the outset, I would like to thank Rupesh for such an exhaustive, taking us through the journey of from the history till what all has been done. There are a lot of changes which have occurred thanks to the court's publications and the work everybody has put in. So thank you, Rupesh, for highlighting all these. And I don't have anything else to say, but commend Rupesh and the team for such an exhaustive work done.
Thank you, Kalpana. Thank you.
Yeah. So to begin with, I'd like to ask a question based on the epidemiology. Like what you explained in the first part of the talk was fantastic. So a simple question is that are we seeing a true rise in ocular tuberculosis, or is just better recognition, or it is overdiagnosis?
I will say both. I think it is a better recognition that is definitely there. But at the same time, I'm also worried. And I think we were worried when we started this COTSCON group and some of these things that sometimes there is a overdiagnosis because with so much of thing going on. And it's like that, the same phenomenon. You see something, you go out, you see a movie, you just try to kind of mimic. So I'm sure tomorrow when people run the clinic, they will see every patient as an ocular TB patient kind of thing. It will linger on for few days, and then that just leads to that. So people need to be a bit careful and don't overdiagnose, because otherwise it will they do. But of course, better recognition, better awareness is there. So it is a mixture of both, Dr. Ganesh.
Dr. Chitranjan, if you can comment on this presentation. Wonderful presentation, sir. It's an eye opener. Anyways, we are going through lots of new things that we saw in presentation in terms of COTS calculator that you have devised in your study, and how we see the different spectrum of the disease itself. Dr. Chitranjan, if you can come in with your
Yeah, yeah.
comments.
So again, thanks the entire team for including me here. I'll just add a few points. My journey for tuberculosis, I'm connecting the dots. Dr. Rupesh, myself, uveitis, tuberculosis. So Dr. Rupesh has been one of the mentors who has really guided in research and to start with uveitis. And my thesis topic was ocular tuberculosis, and none other than Dr. Ratinam Madam in Arvind Eye Care System, Madurai. And there I was exposed to the management of tuberculosis. And as you have seen, as TB is very vast, so also Dr. Rupesh research in ocular tuberculosis. And after so much of research, he has told that, see, 80 to 85% and 80 plus steroid 82%. That means steroid is not very much, or there is still a lot of questions around that. So what we were doing in the practice, ATT is a must plus low dose of steroids, except the patients where the macula and the optic nerve or the peripapillary region was affected. That means from that point only the journey started, and it was very enlightening to see all the work of Dr. Rupesh over here. This is a generalized comment only. Any particular questions, anything I want to take? If maybe ask, I'll take.
Yes, I think we'll start with the questions in the chat box. The first question to Dr. Chitranjan is about how to clinically differentiate serpiginous and serpiginous like choroiditis.
Yeah.
Yeah.
So Yeah, Bobby. See,
Uh,
this is
So
a question.
what I was thinking, sorry to interrupt, because I was just thinking, Manish, because Dr. Kalpana has answered, should we take up more questions, or because Dr. Kalpana has very nicely answered all those
Yeah, yeah,
questions.
yeah. Kalpana Madam has nicely answered.
This is very
So
detailed.
I'll add one point to that, what
Yeah.
Kalpana Madam has told, that maybe sometimes the activity, as Madam has told, the RP changes and thickness in the OCT we get. Sometimes FFA, if we do, that is invasive test, or even autofluorescence we do, the edges will be, fuzzy and whitish. If we are getting, then probably the activity is there, and in those cases we must go for ATT, and like the threshold for treatment should be low. Otherwise, Madam has nicely answered that serpiginous like or serpigenoid term, that is preserved for the TB associated, where vitritis will be there and history of TB will be there. Patient benefited from ATT. Otherwise, serpiginous choroiditis is a autoimmune variety kind of thing. And just to add, as Bhabik was telling, the cover page of ophthalmology retina of this month is a typical serpigenoid tubercular serpulent choroiditis, again contributed by our team.
True. So, to skip all the questions which already been answered, the one which is not been answered was just asked recently by Dr. Sarang Hansraj. In a case of patient who does require steroids and immunomodulators along with ATT, how to devise the end strategy, and does ATT end first or immunosuppression or both together?
Very
This is
nice.
for all the panelists.
Hi, Sarang. So very good and very practical question. So first of all, each case is different. So let's say we talk about a typical case of a serpiginous or a posterior uveitis, and you start a patient on anti-TB treatment. So first of all, for me, it is anti-TB treatment first, and then after that, steroid will come. Immunomodulatory does not come into the picture, and you start with that. And then while the patient is on it, one of the things which you have to remember, corticosteroid has a cross reaction with rifampicin. So when you give corticosteroid, the bioavailability of corticosteroid come down to 66% than what you give. So you might have to consider giving a higher dose of corticosteroid. So you go with your 4-drug regime of anti-TB treatment, and then along with that, oral corticosteroid, which can be started 1 day or 2 days afterwards. So go ahead with the treatment, continue to observe the patient, and then slowly you stop your anti-TB, the corticosteroid treatment, which is like 3 months to 4 months. So you can taper it down 3 months, I will say, at least, if not 4 months, and then your anti-TB treatment continue for 6 months. So that's the standard kind of a thing which I follow. I'm sure other follow differently, but after that, if the patient is responding and patient has responded, then at 6 months you stop anti-TB and then you continue to observe the patient. But for example, so to answer your question, the steroid stop first and then anti-TB treatment goes on later. But let's say if the inflammation is still there, you still have ages, you still have, when you do autofluorescence still comes up, you continue with the corticosteroid. And at some stage where you think there is a lot of more inflammation, more aggravated form, and you corticosteroid not able to control a patient, as side effects of corticosteroid, you might consider adding immunosuppressive agent, and that will continue. Now, after 6 months, it's a difficult call whether you want to continue for 9 months or 12 months. So some of the patient I do consider, no magical formula there. It all depends on that, how convincing you were with the diagnosis. So if the lesions are active, you continue for 9 months, and along with that, the corticosteroid will continue. After that, the treatment will stop, the anti-TB, and then you continue with the corticosteroid. So what are the reasons for treatment failure with anti-TB in a patient whom you suspect? There can be possibly 3 or 4 reasons. One, it was not a TB to start with, ocular TB. B, the patient has multi-drug resistant TB, which we do sometimes test, but let's say in a practical setting, you're not doing test, so it can be a resistant TB. Third, the patient either was not compliant, or your medicine was not enough, or your immunosuppression was not enough. And fourth, the disease is just very severe for your medicines to control. So these are the 4 causes which I found typically one of the patients that fit into this thing. So those are some answers. So Kalpana or Chitranjan, if anyone has any comment.
So,
No, I agree.
can I take it?
Yes,
Yeah.
ma'am,
Yes,
please.
Yeah,
Yeah.
please.
So actually, till recently, we had studies from the Singapore group, which said that you would need 9 months of anti-tubercular therapy. And now we have one study from, I think, Basu's group, and they have done an RCT kind of, but it's a small sample size, where they have said 6 months is okay. But the problem is, ocular TB is an extrapulmonary tuberculosis. So generally, extrapulmonary tuberculosis, we ideally would prefer at least 9 months and above, or a year. And again, for me, it also depends on the type of phenotype which you're seeing. Most of the time, if they are responding well to the anti-tubercular therapy, we generally give, and if the lab parameters are okay, we try to complete at least 9 months to 1 year of anti-tubercular therapy in most of the cases, mainly because if they develop a recurrence, it becomes difficult for us to understand whether it is the duration was short, and or was that the problem, whether there is a recurrence which has occurred. So most of our cases, at least our ID specialist prefers 9 months to 1 year if they are tolerating the medicine well. Now, steroids generally I give depending on the immunological reaction which you're seeing. And from our experience, what we have seen is people with the serpiginous like choroiditis and children with tubercular uveitis who have the intermediate uveitis group usually have a heightened immunological response. So these are the cases which require steroids for a longer period of time, mainly because the serpiginous like choroiditis generally are more prone to develop this paradoxical hypersensitivity reactions, which we usually see in the eye. And this can be well assessed by autofluorescence and OCT, like what Dr. Chittaranjan said earlier, that we could use these to monitor these patients over time. And if you still see activity when you're tapering the steroid, you kind of continue the steroids a little longer. So in our practice, we have felt in these two groups, they have required the longer duration of steroids in comparison to what we see with retinal vasculitis, that group. So these two, I think the immunological reactions are very high. So that's the reason we continue steroids. So if reaction still occurs even after this course of ATT and you've ruled out all the other possibilities, then of course we have to consider immunomodulation in these cases.
So thank you so much, Dr. Kalpana. Dr. Ganesh, any questions you want to ask?
Yeah, absolutely. Ma'am, I had a patient today itself in the OPD, and the patient had already taken TB, ATT for 6 months. First of all, the challenges of a patient having ATT. One, he was not tolerating the medicine very well. How do you counsel your patients if they are not tolerating the medicine well? One, second is the risk of ethambutol toxicity, and how do you handle those patients who actually become toxic to ethambutol. And the last one is uh, once you have given an ATT of 6 months, or say for that matter 9 months already, what antibiotic other than immunosuppression would you actually consider if there is episode, which is a second episode, after say a year and a half? This question is to both Dr. Rupesh and Dr. Kalpana and Chitranjan, please.
You can go ahead, Kalpana.
You can take it, yeah.
Kalpana.
So generally in our care, what we normally do is we start anti-tubercular therapy along with the pulmonologist or an infectious disease specialist, mainly because if they don't tolerate the medications, what they do is the protocol is after 2 weeks, generally we check the liver enzymes. And we do see in our population many times the liver enzymes going up, or these patients are not able to tolerate anti-tubercular therapy. So in these cases, what they normally do is stop the 4-drug which combo which you are getting, and what they do is they introduce the drugs one by one to see which one is actually causing the increased liver enzymes. So most of the time, when they do this, gradual increase, they seem to tolerate these medications better. But if they are still not able to tolerate, and now I think the government of India has, the National Tuberculosis Guidelines have included moxifloxacin in many of these cases with extrapulmonary tuberculosis as well. So in case they don't tolerate these medications, then we go into a different combination. But the problem is we don't have much literature on this particular regimen, unlike the conventional regimen. So as far as possible, we try to stick to the conventional regimen wherever it is possible. And sometimes we need to make certain changes depending on individual patients, how they react. Coming to anti-tubercular therapy, the ethambutol-related toxicity, generally what we have seen is this ethambutol-related toxicity is pretty common between 4 to 5 months. of the maintenance phase when we are in. And that is the reason why it is important to check the color vision at every visit, color vision, and if possible, the fields also, because by 3 or 4 months, you would see some improvement in their inflammatory status and vision. So, which will also help in terms of assessing their color vision. So ideally for us, whenever we see these patients, the vision and the color vision are very, very crucial. So whenever we see that there is a disproportionate change in the vision, which cannot be accounted for through your fundus examination, that's when we consider that this patient could have ethambutol related toxicity, and we stop both ethambutol and INH because you don't know at which is the drug which is causing that. Another interesting finding is there is a small subset of patients who may not come with a drop in vision, but they can come with subtle symptoms such as photopsia, difficulty to see light things. So we have published paper on cone dysfunction. So if you do an ERG in these patients, they have cone abnormalities. So it is very, very important to, whenever the patient comes, to look at certain symptoms such as this difficulty to see bright light, because these could be starting points of ethambutol related toxicity. So I think if we are aware of this condition, and this is the time frame generally we see, I think we can, and the earlier you stop these patients, the faster the recovery is. And what is interesting is many times these patients are not on pyridoxine. So they are just given ATT, but they are not given any vitamin supplements along with that. So it is important to ensure that these patients are also on B6. And, whenever you see certain, changes in vision or color vision, it is important to stop the drug, even if there is a subtle doubt. And you can always shift them to pyrazinamide, and better to put them on vitamin B12 and zinc and folic acid supplements as early as possible. We also check their peripapillary thickness in these cases and follow up that also in case there is a doubt over time.
Okay, thank you so much, Dr. Kalpana, for the detailed insights about ethambutol toxicity. My next question is based on the AI aspect of Dr. Rupesh's talk. So, Dr. Rupesh, can AI-based retinal imaging or say fundus screening help detect ocular TB early in high burden areas? Do you think in the future we can look at certain kind of
I think
patterns?
very valid question. I will say stepwise. So first of all, we need to have good quality images because a lot of cameras are there and a lot of noise is there. And as a human grader, we can then read through those noise and can differentiate. But for AI, noise may not be the good idea. So I think first of all, we need to have a very good high quality images. So let's say if we have that and we have AI algorithms in place, yes, I think there is a significant scope of AI playing a major role in terms of particularly as we describe. And this is what AI want is to understand the lesion between serpiginous and like choroiditis and serpiginous choroiditis. So it can help in differentiating one from each other. Number two, also about the disease activity. Number two, about the progression of the lesions. Number four, about other hidden lesions or subtle lesions, and also about predicting which lesion will do well or not. But having said that, this is the future. The problem is between the building that model. The problem is that unfortunately, a lot of models now you know that diabetic retinopathy, a lot of models are there, AMD, glaucoma, there are many models. The problem is in this building the model, there's a lot of confusion and people have come up with the model with 15 cases, 20 cases, 30 cases. There are quite a number of papers based on those smaller sample size. So you need a reasonable sample size where it can show to the AI model different heterogeneity. So you need to show the different features, different thing there. And that is what it is lacking because the ground truth for any AI model need to be perfect. So for the AI to give you. But the problem for us is the ground truth is missing. So let's say if I tell these are the 100 classified cases of serpiginous and you need then 100 classified cases of serpiginoid kind of thing so that it can differentiate properly one. And these are all proper one cases, not just randomly picked up. So a lot of people have reached out to me, can you give us your images or this thing? I said, it's not going to be helpful because these are not properly annotated, not properly labeled, not properly with the associated data. So you need data, you need images. Therefore, we build up now registry which will have both data and images. But I think it is a challenge to get that. And till the time we get it, I think we are far, far away from developing any AI model for any of those things. So I will say, if any AI model comes to a clinic, take it with a pinch of salt, check how that model has been built before you really do it. I think I will not probably say any current AI model for uveitis is anything which anyone should be using in the clinic. I think our human eyes are better than any of those things at this stage. In future, we don't know once we get that, but not yet ready. Yeah. Yes, Dr. Sunil sir. How are you? How is Rishikesh?
Yeah.
You have hardly left any stone unturned.
No, no, sir. Blessing, sir.
So, any other questions from any of the participants?
Bhabik, can I ask one question to Rupesh sir and Kalpana madam? So, as Kalpana madam touched upon the moxifloxacin drug, there are like recent interest on intravitreal moxi plus anti-VEGF, that is bevacizumab for choroidal granulomas. So, where are we on these, and is it very promising? What are your takes on this?
Rupesh, you want to come in?
So, I don't have. Thanks, Chitranjan, for this thing. So, in 2014, we did a study on oral moxifloxacin, and that time, one of the hospitals in London, they were using it as a regimen, and it was quite interesting study. And also did a study on linezolid also. So, we found moxifloxacin as a drug of choice also in case if someone wants to, but that was for the oral moxifloxacin. Now, when it comes to intravitreal drug therapy or monotherapy, so first of all, uh, for all those people who really like intravitreal agents, so you can consider intravitreal in case if it is a vision threatening or some of those lesions there. But we need to understand TB is a systemic medicine, systemic thing there. So your intravitreal is not going to kind of take care of all the underlying thing there. It can probably give you some time. If you're vision threatening, reaching the fovea and all, then maybe some of those cases, though, I think you can consider. But if you really want to kill, and because you need to understand that it's there, so I think eventually the mainstay of therapy for me, I was quite fascinated, and we did a lot of research on can we develop some intravitreal regime, because ocular TB is so secluded, we don't get any evidence in pulmonary TB. Why should we? But of late, I realized I think it is better, because I got patients who came with the symptoms of ocular TB and signs suggest ocular TB, but after the treatment, they said, oh, their spine problem has gone, their body ache problem is gone, they are completely energized. At least I've got 10 over patients, they are feeling completely different, and which they were not able to account for. They were every now and then visiting some other doctors for different reasons, musculoskeletal or some of the other thing. I think there will be some subclinical TB happening somewhere in the body. So if you give that systemic TB, probably it will eliminate it and it will help the patient. So I'm not a big fan of intravitreal agent if it comes to the treatment of ocular TB as of now. But only when we are running out short of time and we know that it is vision threatening, then in those cases, just to buy time maybe. Yeah. I don't know, Kalpana. Yeah.
Can I just add one? So the problem, sir, with intravitreal moxifloxacin is it's quickly eliminated from the vitreous.
Yeah.
I think it's
That's all.
hardly 1.5 hours it stays. I mean, the maximum, the
Half-life.
life thing which is there. So the drug actually is eliminated quite quickly. So that's the reason intravitreal moxifloxacin is not very useful. As what Rupesh said, like in some cases, for example, serpiginous like choroiditis, and suppose this patient is a very high diabetic, so you're not able to give the steroids. We do give short-acting DEXA, in individual cases, suddenly to reduce the edema. So that time we combine it with intravitreal moxifloxacin. Secondly, with regard to anti-VEGFs, We published the first paper case report in 2012, I think, or 2011 in Eye on this tubercular granulomas which are vascularized. From our experience, what we found is if these patients have these wrap-like lesions, like the granulomas have the wrap-like lesions, these are the cases which generally does well with anti-VEGF therapy. But I think the papers which Dr. Manisha and I think Rima's group had recently what they have published, they have mentioned that the size of the granulomas have come down with anti-VEGF therapies. But what I feel is in our practice, if you see these RAP lesions, or if it is associated with a lot of SRF around, these are the granulomas which does well with anti-VEGF. But again, this is not a substitute for anti-tubercular therapy. You would still have to give anti-tubercular systemically. But to reduce in case if there is a lot of SRF, hemorrhages, in those cases, the anti-VEGF therapy have been found to be useful. So we had the case which we had published long ago in 2011, I think, was a patient who was with miliary tuberculosis who had tubercular granuloma, I think. But what happened was he manifested SRF and RAP-like lesions around 6 months of anti-tubercular therapy. So at that time, we knew because systemically he was already getting better with anti-tubercular therapy. It was only the eye which was worsening. So we did give 3 injections of Avastin at that point of time, and the whole granuloma regressed very well. So it was more to do with the RP RAP lesions which had caused that SRF, and that actually had come down with anti-VEGF therapy.
I'll just show one photo because I have this, and very interesting. A lady came to my clinic, a 70-year-old. This was a granuloma on the iris, and the patient had TB positive and all. Given no topical steroid was given, patient was started on anti-TB. After 2 weeks, the patient came like this. I was surprised whether is the same patient. I was like looking into the notes. Completely disappeared means I don't even know means how effectively it can work. But this was a Chinese female, and actually no steroid, no nothing, and only with anti-TB treatment this just the granuloma disappeared. And this is the real, no fabrication, no AI tool, nothing easy. Just saying. Sometimes you get some of those surprises. Not that every time you're lucky, but in this patient we were very lucky to eliminate this thick granuloma only after the oral anti-TB treatment. Yeah, that's it.
So I agree with Rupesh. We've had patients like this who've just started anti-tubercular and things just settled. But the problem always is, just like in the lung, it can cause an immense immunological reaction. And here we're talking about the eye, where that much of immunological reaction can really affect and even can cause vision loss. So that's the reason we are always worried, and we do give steroids along with anti-tubercular.
Along with that, absolutely, absolutely.
Yeah, just to close where do we stand on IGRA, Monto, clinical suspicion of TB? Just for the audience purpose, how do you just simplify it?
Kalpana,
Or
you want
someone
to say
who's
that?
suspicious of
Indian context.
Yes.
So, I mean, this is always a dilemma for us. And for us, ideally, I think as a clinician, for us, the phenotype is what is very important, what you're seeing. Are you seeing, if you're seeing a granuloma, if you're seeing serpiginous-like choroiditis, if you're seeing an occlusive type of retinal vasculitis, I would probably, these would add evidence for me. And probably this will help me convince the patient and the physician better when I discuss all this. For us, in addition to Mantu and Quantiferon, we also do HRCTs in all our patients if you're planning to start them on anti-tubercular therapy. And if we have evidence indirectly in the form of calcified focus or apical fibrosis, this adds on to your existing evidence, and you are more you can convince the patient a lot better why he has to be on anti-tubercular therapy. So for us, Mantu Quantiferon is just an added evidence for convincing, but mainly it goes on the phenotype. Now, to add to all this confusion, we also have something called the CYT test, which is now approved by the government of India. And the funny part is we are getting varied results. We get Quantiferon positive, CY test negative, or CY test positive, Quantiferon negative. So it is becoming increasingly difficult to interpret these results in our context. But the fact is, if the clinical phenotype justifies, and if you have an added investigation which is supporting, either in the form of MAN2 or a quantiferon TB Gold, then it becomes easier for us to convince both the physician and the patient why this patient has to be on antitubercular therapy. But if it is just like a non-granulomatous uveitis, or something which is actually a fuchs and it doesn't fit into this whole thing, then we don't pay much attention to these particular tests. But if you have phenotypes which are very strongly suggestive, that's when we take all these indirect evidences very seriously.
So just Dr. Ganesh, just to continue to add to beautiful points, all the very practical points said by Dr. Kalpana. I also spend time on history taking and the history of exposure to TB, the past history of TB also can contribute. Endemicity, of course, is taken into consideration, but I've kind of started giving less weight the way the world is traveling. Everyone travels a lot. I used to kind of think, but it's not that the American cannot get TB or all Indians have TB kind of thing. I think that's a very wrong this thing. So I think the endemicity has a role, but of course the history taking. Other slight one more thing which I try to do besides this thing is that so some of the straightforward cases is okay, but sometimes if you have a clinical suspicion of some other infective thing, so of course you do syphilis and other things. So other things are negative. It will be helpful again the other negative test to kind of think about the TB. But the problem comes is if you have got a syphilis positive and if you got a TB positive or suspecting TB, then might be a confusing picture. But of course the other test which you try to rule out also can be helpful. Last, everything okay, negative and all, you convince. I think one of the person asked on the question is that if everything is negative, what do you do about it and you have a clinical suspicion? So in few cases where we have a very strong clinical suspicion like a granuloma or if you have very poor evidence, so most important is spending time with the patient, explaining them this is a uveitis, this is what it is happening. So spending good amount of time telling them about how TB. So I typically take a pen and paper. I draw all the diagrams with them. So keep separate half an hour for them, explaining them, and then tell them that standard of care is maybe corticosteroid or steroid therapy. But in addition, giving the anti-TB treatment will prevent relapses and may result into complete cure. So setting the expectations right at the beginning will be very nice because sometimes the patient has thinking, oh, I've taken 1 month of NTTB, still things are coming up, and then that false expectation. So once you set up the expectation, patients are with you and they will journey with you. So it is very important that you spend time, get that expectations right, and then you move forward. Either way, even if you've got a good evidence, even if you've got a weak evidence, it is extremely important in this patient because first thing which people are going to say when they go out in the community social, they say, oh, you think ocular TB? No one, because no one knows about it. They go out and tell the people that I went to the eye doctor, he's given me TB for medicine for the TB in the lung, kind of thing. That's what people say. People, there is a lot of myth. And so it is very important that you educate them. So I can tell you in most of the social functions which I've got in Singapore, and I've not sat across any dinner table of 10 where one of the patient has not stood up and said, I've been diagnosed with something called as uveitis. You can imagine uveitis can be so common, and where on a one dinner table one person has stood up. It's not just about the cataract. It's just that awareness is not there about uveitis, and forget about the awareness about ocular TB. So I was trying to work with a scientist who has done a maximum amount of work on therapeutics for TB medicines. He has done wonderful medicines. And I said, okay, let's do a project on ocular TB, some intravitreal drug therapy, an animal model of TB, ocular TB. He said, what? And he has 30 years of experience. He said, does that entity exist? So this was scientists talking about it. Forget about the clinicians and the community. No one believes that such an entity exists. So I think first is education, spending time with them, and then probably kind of considering and embarking on the treatment. Otherwise, we'll lose that battle if we don't educate our patient.
Yes, thank you so much, Dr. Rupesh, for those insights. I'd like to ask Dr. Ganesh to uh, give a vote of thanks. Wonderful comments and questions by the participants and the panelists. Thank you so much.
Thank you so much, Dr. Rupesh Agrawal, sir, for gracing this occasion. This is a very important day. Ocular, it's a World TB Day, and you came and spoke about TB, its importance of being recognized as a different entity, and how prevalent it is in our community. Thank you, Dr. Kalpana, for giving your insightful thoughts about various perspectives in Indian scenarios, and Dr. Chintaranjan for raising important questions in diagnosing ocular TB. So I would like to thank everyone who joined here on this platform to witness a very, very nice session taken by Dr. Rupesh Agrawal, sir. More than 90 people joined it. So thank you, everyone, and looking forward to more such master classes from our different speakers. Thank you
Thank
once again.
Thank
thank
you
you.
all. Thank you. Have a good
Thank
night.
you.
Thank you.
Thank
Thank
you.
you,
Bye.
everyone. Bye bye.
Thank you. Bye.
Thank you.